introducing our next speaker, Dr. Stevan Bruijns. This is the last talk before tea break. Apologies. Stevan is the editor of AFGEM and also the head of the Emergency Medicine Cape Town PhD program, and he is performing clinical duties at Khalicha Hospital.
Okay, so we've got some medical students here. Hands up. Medical students, some nurses, doctors, pre-hospital. Okay, great. This talk is just for the doctors, so okay, it's not. No, it is. No. So, who of you here, hands up except me, have dealt with a dying patient or been involved with a dying patient? A dying young person? Dying child under 5? Dying infant? Newborn? Can you remember? Can you think back to an event? Can you remember the emotions that went with it? The emotion of making the decision? The emotion when you had to speak to the family? Perhaps you didn't have to. If you do, then you'd be familiar with this it's the nature of emergency care that some of our patients will die, and it is the nature of death that sometimes that is meant to be. Right? Just by living in Africa, our mortality rates are higher than anywhere else in the world. Our your life expectation is 10 years lower than anywhere else, and I'm including countries in other regions of the world that also have low income or low and middle income issues. Yay, it's not recording anymore. Our patients die young. Our patients die violently. They die from HIV. They die from TB, strokes, acute coronary syndrome, injuries, and other infectious diseases. We make decisions just like everybody else in the world does on who needs to be resuscitated and who don't, but we've got a little bit of a different problem attached to when we make decisions, and that's this little tiny thing about resources. We sometimes make end-of-life decisions based on the fact that we don't have the resources to manage patients. And that is a difficult call to make, because everything inside of us shouts out not to do that. We will not accept the fact that we have no resources, but it's something that we have to accept when we are doing clinical care, especially when we're caring for potentially patients who are dying. Example, there was talk earlier on about thoracotomies, and it's true, yes, I can open up every chest that comes through the door, but what then? Where does that patient go afterwards? I can intubate every patient using international criteria. Where's the ICU beds? How's that patient going to go from my district hospital to the hospital with the ICU bed if we don't have ambulances or trained people on vehicles or a timely ambulance available to take the patient there? And in the mix of all these things, we need to make these decisions. So, true story, a few weeks back I was dealing with a patient. It was a 16-month-old little girl, and she was diagnosed with cerebral paresis. She's actually doing very well, wrote a health card. Physiotherapists, occupational therapists were commenting on how well this girl was doing on her milestones. Not as good as obviously a normal child would, but nevertheless this child was doing well. The inevitable happened, and she had an aspiration, and she came into our department with respiratory distress. We intubate it because that's something that we do, and we have an opportunity to do that early, and you don't always have the opportunity to do that later on. But when it came to transferring the child and finding that there's no beds available for this little one, well, I can tell you it was a very difficult conversation I had to have with that mother. It was a very difficult conversation. And beneath all of these emotions of dealing with end-of-life care, all of the fights we have with regards to resources, there's one thing that we can all do and that we can all fall back on, and it's this: first do no harm. First do no harm to the patient, first do no harm to ourselves. We have to be honest about these things to ourselves. We have to be honest to our patients, and we have to be honest to our next of kin. I know I've been there. I've been the doctor that continues resuscitation because the alternative in admitting that I am failing this patient is just too difficult. I'd much rather continue resuscitation and now this patient is dead and I can say, oh, we've done all we can. You know, and you could see, I mean, we were... And all through that, I knew that I wasn't being honest to myself. I knew that patient was dying minutes into that resus already, but I still did it. Let's not kid ourselves. It's not an episode of ER. We have to be honest to ourselves. We have to be honest to our patients. We have to be honest to our next of kin. So how do we talk to patients? Well, there's some very, very clear ideas on how we would talk to patients, and I'm going to give you a few hints. First one is, I've got a patient I've made a decision on, this person is dying, there's nothing I can do, or resources is completely outstripped, and this person I've made a decision they are not going to make it. If I need to talk to the next of kin, I need to prepare. You need to prepare. Do not walk into the room where you're going to talk to the family and not be prepared. You have to prepare. Look at the notes. If it's a time of the day where you can speak to patients, usual caregivers, and so then you do that. Speak to your colleagues. All right? We have a cultural issue as well and a language issue in our environments where we work. Where I work, the vast majority of my patients and next of kin would not understand me if I try and break down something as difficult as end-of-life care in English. You need a good nurse. You need somebody that you can trust, somebody who speaks the language that you can take along. If you are fortunate enough to be able to speak the tongue which the patient and their relatives are, then that's fantastic. I am not. I take a nurse with me that is skilled in breaking down what I'm saying in the language for the patient. And you take some tissues, all right? It's important. You take some tissues. I'm going to come back to why. You greet everybody in the room. Make sure this is in a private area. We don't always have private rooms. Where I work, on my shop, we've got a private area we can take. But it's not ideal. I'd much rather have something with a door I can close, but we don't always have that luxury. But you want as much privacy as you can get. You greet everybody. You greet everybody, all right? You owe it to them. You identify two people in the room whilst you're greeting them. You identify the significant other. Your patient who's dying, who's the significant other? Mother, father, aunt, uncle, brother, sister, wife, husband, son, daughter. You find out who is that significant other, and I'll come back to why. And then the other thing is you identify the representative. In some cultures this is stronger than others, but I have encountered this in just about every culture that I've worked in. There's usually somebody in the room that's more level-headed than the others, and usually that person is making the decisions. You need to identify these two people. You introduce yourself and you introduce your nurse. I am Dr. Stevan Bruijns. I am the emergency physician taking care of the patient. No, we don't say that. I'm Dr. Stevan Bruijns. I am taking care of your son, your daughter, Mr. Smith. All right? And then we fire our first warning shot. You don't stand and fire a warning shot. You crouch down next to the significant other. All right? If you feel that you need to touch the patient, sometimes, not the patient, the person, you have to culturally judge that. But usually the advice is we touch the elbow first, and if the patient's comfortable with that, we touch the shoulder. You never go for the shoulder first, all right? Little hint, body language. And what's the warning shot? I'm afraid I've got some really bad news. Your son is dying. Your mother is dying. Normally, this will be followed by an outpour of grief. Depending on the culture, this may last a few seconds to several minutes. This is normal. People will be angry. People will be upset. People will be crying. You take your cue from the representative. This is the second most important person. When the representative has settled themselves, what you do is you explain the situation. You don't use jargon. You don't, okay? Here's what we say, or rather what we don't say. Do you want everything done? Do you want resuscitation? Well, of course I do. Of course I want everything done, because what's the alternative? Do you want nothing done? No. So it's a bad phrase to use both of those phrases. There's nothing more that we can do. What an utter load of rubbish. All right. I am sorry. It's not your fault. It's not your fault. You don't have to apologize. You can be polite, but you don't have to apologize. Instead, what we're going to do is we're going to establish goals of care. What is important at this time for the dying patient or for the relatives? His wife is on her way. Will he make it until then? We will try. The daughter is coming from far away. The family will be here in a day from the Eastern Cape. Will he make it? We can try. What's the goals of care? What is important at that specific moment? And it may not be clinical, and quite often it is not. Doctor, we just don't want him to be in any pain. Yeah, we can do that. But establish the goals of care very early on. Say over and over that we would like to allow a natural death. A natural death. Natural death. All right. There's nothing unnatural about dying. We are dying from the very day that we are born, even before. There's nothing unnatural about it. I want a natural death. Maybe you want one too. But we say this to the patient, to the next of kin. We want to allow a natural death. This is the situation. We want to allow a natural death. We say that there's still a lot that we can do, because there is, and I'm going to come back to that. It isn't that there's nothing left to do. There's actually a lot that we can still do. It's just not active resuscitation, it's active palliation. And there's a different, but it just heads in two directions. It still takes a lot of work. There was a bunch of nurses here. They know how difficult it is to look after the dying patient. It's not easy. And then finally, when you leave the room, you say that I wish that things were different. All right. Some powerful things to remember. Naturally, I practice whenever I do this. I usually write down what I want to say. I never follow the script, but it just helps you to order the things that you want to say. You owe this to the family. And then back to the patient. I'm not going to point any fingers because there'll be fingers pointing back at me, but who has been in a ward, in an emergency department, where at the handoff, oh, the patient in the corner is dying, and there they are, lying in their pool of vomits, blood, urine, poo. All right. And I've walked past that when I was younger. Maybe you have too. But we don't do that because the standard that we walk past is the standard that we accept, and we do not accept that for our patients, even in death. How do you want to die? How do I want to die? Well, I can tell you how I want to die. I don't want to be in pain. I don't want to be breathless. I don't want to be restless. I don't want to be drowning in secretions, and I don't want to be vomiting. And you know what? We can do something for all of those things. We can do something for all of those things. How do we treat dyspnea? Oh gosh. How do we treat dyspnea and pain? We give some morphine. All right? How do we give morphine? Orally. Here's my patient. Okay, no, it doesn't work. IV, well, the patient's going to go to the wards. How's the nurse going to give IV morphine? We give it subcut. 2.5 milligrams, subcut, every 10, 15 minutes until the patient's dead. No, until the patient's comfortable. But won't the morphine kill the patient? Best evidence says no. Best evidence says the patient that you manage in this way actually lives longer than the people that you don't give it to. All right. So there's no evidence base to say I'm pushing morphine every 10 to 15 minutes that would kill the patient, because it doesn't. All right. For restlessness, same. Midazolam, 2.5 milligrams subcut. We can give something for secretions. You can probably think of loads of drugs that we can give for nausea and vomiting. And that's it. I'm going to be finishing off with one more trick, which I learned actually from an American doctor, which is odd, because who learns anything from Americans? And that's how we pull the tube, because sometimes our patients is intubated and we've made this decision to pull the tube. You need 5 things. You can see I'm not raising my arms. It's so embarrassing. You need 5 things. You need a towel, you need some gloves for yourself, you need 20 ml syringe, you need a scissor and some suctioning, and that's all you need. I like to have the family in the room if they want to be there. Never force them. Usually the representative wants to be there, and sometimes the significant other wants to be there. If the significant other is coming into the room with you, you get a chair and they sit next to the patient and hold the patient's hand. All right? You place a towel on the patient's chest, just under the neck. All right? You take the scissor and you cut the strapping that's holding the tube in and place this on the towel. The necks need to be done in a very fluid movement. You aspirate the air from the bulb, disconnect the ventilator, pull the tube out onto the towel, fold the towel over, wipe the patient's mouth, take the towel with everything in it away, and as you leave, you switch off the ventilator. You leave the patient with the relatives, 3 to 5 minutes, and then you check in. Sometimes the patients will go quickly, sometimes they'll still be alive for days. When they die, we go in and we pronounce them dead, and we ask the relatives to wait outside while the nurses prepare the patient. Anyway, so I'm sure that will get you all talking during tea time. That's all I've got. Looks like I ran over. I didn't intend to, but I did pause a lot more than I did when I practiced.